The Virtual Curbside is a production of the Utah chapter of the American Academy of Pediatrics, the Utah AAP, working together to improve children's lives through education, advocacy, and networking. Hi, this is Paul Wirkus from the Utah AAP. Welcome to this week's edition of the Virtual Curbside, where we bring pediatric providers together with subspecialists to get smarter about all things pediatric and better acquainted as a community of caregivers. The Virtual Curbside is brought to you in part by a generous grant from Primary Children's Hospital. Primary Children's Hospital, the child first and always. Welcome back to the Virtual Curbside. We're here again with the estimable Dr. Pete Lindgren from Salt Lake City, a superb general pediatrician and Kaiser of all baby issues in the Canyons area of Intermountain Healthcare. Is that true?
It is true, Paul.
Okay. All right. Glad to hear. So it's interesting to me, the European emperors, the cognates that come, from Caesar. I've accused you of both now, of Tsar and Kaiser. So we'll just call you Julius Pete from now on. Have you developed any disclosures since last week?
I will again disclose that I am no expert.
Well, I think you've argued otherwise. All right. This week we want to talk about vitamin K, and this is a topic you follow very closely. And I think that that you have the data to point out that in your realm, that vitamin K refusal is increasing.
It's increasing at an alarming rate, Paul. When we looked at our data in 2018 in the entire Intermountain system, so 22 hospitals that deliver around 26 to 30,000 babies a year, we were at about a 1% refusal rate. And at the end of 2023, we were about 3% refusal rate for vitamin K. And to date this year, we are at about 4.5%. So in 2024, we're at about 4.5% of people who are delivering in our system who are refusing vitamin K at birth.
That's a lot, both comparatively speaking, and also, and we'll come back to this in a minute, but when you talk about the number of deliveries that you look at and the published complication rate, it puts you on edge because it increases the likelihood that you see actual stuff happen.
Well, and I think what's happening is we are beginning to see the complications of those. So that can be a very dramatic finding. There was a baby that followed up in one of our clinics who came in at the 2-week mark who had a OFC that had greatly increased, had definite signs of increased intracranial pressure, and had a CT then MRI that very nicely demonstrated bleeding in the subdural space. And that baby had a hospitalization, had an EVD placed, and spent about 2 weeks in the PICU, and thankfully did well. But that was a baby that did not receive vitamin K and had a complication. And the complications, of course, can be rather severe. And there is about a 20% mortality rate associated with vitamin K deficiency bleeding. So it's not a trivial problem.
Yeah. Well, let's just review briefly. Why do babies need a vitamin K supplement?
So babies come with a low level of vitamin K. Vitamin K doesn't cross the placenta very readily. And so they have very little vitamin K at birth. And that puts them at risk for coagulation problems.
And vitamin K getting its name from its role in coagulation.
Yeah, that's a pretty interesting story. But yeah, the K being the German or Scandinavian word for coagulation starts with K. It was also the first letter in the alphabet that hadn't been used for naming a vitamin.
So win-win, really, both for the naming and for the availability. We also have a history that vitamin K makes a difference, that when vitamin K was first given, the hemorrhagic disease in the newborn decreased.
Yeah, not only did it decrease, it essentially went away. So, there's virtual elimination of vitamin K deficiency bleeding. So again, vitamin K was discovered by a Danish biochemist in the 1940s. But the hemorrhagic disease of the newborn was something that was identified sort of around the turn of the century. And so it's something that people knew about. And with the discovery of vitamin K and understanding that it was critical to coagulation, very immediately they thought of newborns and the utility of vitamin K. And in the early 1960s, the AAP was recommending giving a dose of vitamin K to all newborns. And so that practice has been going on for the last, 60 years?
With a lot of lives saved.
Yes.
So when we think about hemorrhagic disease of the newborn, there's both a classic presentation. Well, you explain it.
So there's early, which is in the first 24 hours. There's the classic form, which usually occurs in the first 2 weeks. And then there's late, which kind of goes from like 2 weeks to 6 months. And I would just point out that if you don't receive vitamin K, the risk of bleeding goes out to 6 months. So it's a really wide window of time for bleeding problems to happen. So you're not out of the woods if you make it out of the first couple of weeks.
So given that this is a fairly well understood problem and one where the fix has worked quite well, what do you know about why people refuse the vitamin K supplementation?
So there have actually been a number of studies on this, Paul, that have looked at reasons for refusal, and they really kind of group into three main things. There's the concern for harm from the injection. There's a desire for people to be natural, and then there's a belief in alternates to prophylaxis for vitamin K deficiency bleeding. But the harm from injection is sort of an interesting one. So people worry about pain from getting a shot. Sure. They worry about the preservatives that are in this. I think we all kind of have that sort of scarring from the hepatitis B vaccine and thimerosal from 24 years ago. There's a perception that perhaps the dose could be too high. There's concern about vaccines, and sometimes people make the equivalency that because vitamin K is an injection, it's a vaccine, so they don't want to do that. There's also a concern about adverse reactions. So there is a single case in the literature of a baby experiencing anaphylaxis related to vitamin K injection. Believe this case was in Turkey. And, again, we've done this since 1961, and there's a single case. So I think the concern's pretty small from that. There was a study in the 1990s in England that was a small study that suggested an association between vitamin K and childhood leukemia. A number of larger studies have been done that have basically shown that there is not an association between vitamin K and childhood cancers. And then there's also concern that vitamin K somehow might overwhelm the immune system.
Is there, in your understanding, a theoretic pathway for why that would be true? Does it present itself to the immune system?
No. Vitamin K it's important in carboxylating a number of the coagulation cofactors. It also helps with the regulators of coagulation. So I don't think that it has any effect on immune function.
When I'm talking to people, what should I say? Because it is a relatively high dose. Is there a response to that?
Yes. So one of the things is that some of the vitamin K is going to be absorbed quickly into the bloodstream, but quite a bit of the vitamin K is actually stored within the body and is one of the reasons that it's helpful for a long time in terms of preventing things like late onset vitamin K deficiency bleeding. So that dose, which may seem high, has a lasting effect and isn't entirely absorbed immediately.
So like a depot dose in a way, some of it deposited to be retrieved later.
Yep.
Okay. All right. I don't know what to ask about the vaccine thing. Are there preservatives that I should be concerned about?
We could go through kind of the ingredients, and that might be a kind of interesting side note. There are small amounts of other things in it. There's polysorbate 80, there's propylene glycol, and there's sodium acetic anhydrous and glacial acetic acid. So those things, the polysorbate 80 and propylene glycol, are actually helpful for keeping it soluble in a liquid. And the others, sodium acetic anhydrous and glacial acetic acid, are useful in keeping the pH correct for the ingredient. And that's all that's in it. So those are things that are present in many of the food substances that we get and are thought to cause or pose no risk at all.
That seems like a reasonable answer. Tell me about the desire to be natural part.
There's an idea that somehow there may be some kind of advantage to having a low vitamin K. So if in nature there's a low vitamin K in babies, then maybe there's some kind of like evolutionary advantage to that. I don't think we kind of know of any. So that is a question, but I think it's theoretical.
Yeah.
I think some people feel that it's just kind of to be expected that vitamin K is low. And, again, I think when we think about all of the things that we do to prevent adverse outcomes, there's a lot of stuff that we do that I think you wouldn't consider to be natural, but that do improve outcomes.
And is this a laboratory synthesized vitamin?
That is a good question. I imagine so.
I mean, the reason I ask is the other thing is that I know that a lot of hospitals will offer a religious exemption for vitamin K. And as I've looked at that, it doesn't seem like it touches the usual issues of blood products or derivation from animals. All I could find as I looked into it is that one of the things that I read said, why would God leave out an important ingredient? It's certainly a question, but I don't know that it fits any particular religious tradition's objection to treatment of a baby.
I'm not aware of any. And vitamin K is typically derived from plants, and particularly green leafy plants.
Okay. Well, let's talk about the thing that we all wrestle with, and that's the sort of the in-between that, sure, I'm happy to give my baby vitamin K, but I want to find another way to do it. And so we hear things like, I'll just eat a lot of vitamin K and pass it in the breast milk. Does that work?
That does not increase. So you cannot supplement mothers and get increased vitamin K levels in babies.
Either in gestation or while nursing?
Either. And then vitamin K is in relatively low levels in breast milk. So interestingly, vitamin K deficiency bleeding is actually higher incidence in babies that are exclusively breastfed.
Okay. What about oral vitamin K? What about giving kids oral vitamin K?
Paul, this is a dilemma. It is better than doing nothing, but there are no studies that actually demonstrate that oral vitamin K is as effective as giving injectable vitamin K. If you give it orally, you have to give it in multiple doses, which is also problematic. There are no readily available oral forms of vitamin K that can be given to newborns. So the dosing for giving oral vitamin K is actually giving the IM dose orally. And that is hard to get outside of the hospital. There is a 5 milligram vitamin K tablet that can be compounded, but it doesn't stay in solution very long. So it's something that has to be compounded multiple times. So it presents a bit of a problem in terms of doing it, but there are studies that show that it is effective at decreasing the classic form of vitamin K deficiency bleeding, but the jury is out on late onset vitamin K deficiency bleeding with oral vitamin K.
Okay. The other issue is that the general approach to trust of expertise is changed. Things look different, and I've been doing a fair amount of reading trying to understand that why expertise has become so suspect, but that plays into this as well. It may not be a religious objection, but it's a philosophical objection that is based on not trusting the experts.
Do you think COVID had anything to do with that?
I think so. I think in a lot of ways. Although it's interesting because one of the books that I read, I think it's called The Death of Expertise, actually was written before COVID, and then he revised and expanded it after COVID. And he points to a lot of different things. But the point is that I think that there's a lot more likelihood of people saying, yeah, I need to do some research about this. And I think it's hard to know where to send people to learn more about vitamin K, let alone vaccines.
The people that tend to refuse tend to be very well educated. And they do tend to be people who are trying to make good choices for their babies. And I think, what we always learn is that you have to check your sources and you have to be critical about, how you evaluate these things. I think another aspect of this is just, how we respond to fear. Mm-hmm. And one of the ways that we respond to fear is we do things to take control. And so refusing something is a way of taking control. Mm-hmm. It just ends up being a potentially really dangerous prospect.
One of the disadvantages we face sometimes in our role as pediatricians is that in meeting a family for the first time and the first conversation that we're having with them, before we've really had a chance to develop a relationship, I think it's very important that we have respect for the kind of conversation that we're having about this.
Yeah, and I think, respectfully eliciting the reasons that they don't want to do it and being able to really thoughtfully discuss those things. We had a nice story from one of the hospitals where the parents didn't want to do this. They were quite concerned about the ingredients within the vitamin K injection. And the pediatrician there got the hospital pharmacist to come and actually review the things, the ingredients with the parents. And they were satisfied with that and ended up giving vitamin K. So I think, it takes time, which is hard, when you're at the hospital rounding and you got to get to clinic and somebody's, throwing a roadblock in your way. It can be hard to stop and thoughtfully do that. I think, we tend to have our biases about people who refuse things. And I think assuming good intent from parents that they're trying to do the best thing for their baby. And, we have a vested and shared interest in the baby doing well. That's generally a good common ground to approach those types of refusals. And I think, hopefully builds trust around other things, because certainly people that refuse vitamin K are also more likely to refuse other more standard conventional medical practices.
Sure. It's counterintuitive sometimes, but a certain amount of humility that recognizes that sometimes what we see as misinformed bravado is actually fear. And that there are very few situations that I've found where someone shouting at me is likely to persuade me to think differently. And I do hope that one of the things we can do is understand both the details of what it is we're recommending, as well as trying to understand what people's objections are, so that we can, because this is a big deal. This is something, as you pointed out at the first, that has potentially very serious consequences. And I think it's a matter of us being able to have a good conversation. I do think as well that one of the areas where we would probably be well served would be to have more conversations with our obstetric colleagues.
That is a big one. I think understanding that birth center, home deliveries, midwife-attended deliveries have a higher rate of refusal is something to consider. We have reached out and done some education and helped with some writing of newsletters to the nurse midwives. But it's another one of those areas where, we do need to team together around this. And I think having those conversations teed up ahead of time is always helpful. So I think we have met with and talked about some of these cases with our obstetric colleagues. And I do think that is one of the really important things I think that your podcast does too, right? I mean, you are building that community of caregivers who can talk about these things and work together and hopefully improve outcomes.
Yeah, I hope so. I do find that actually having conversations with people, oddly enough, usually leads to more understanding.
I think so. And I think when you approach it with, genuine concern, I think people feel that, right? It's not that the AAP says you have to do this, the CDC says you have to do it. It's, we want you to do it because it actually has been shown to prevent bad things from happening to babies.
Yeah, we've also had a conversation about this. It seems to me that in some ways that we talk about hospital parlance, eyes and thighs, that a baby gets erythromycin ointment and gets a hepatitis B vaccine and gets the vitamin K injection. And I think for one thing, being able to talk about each thing specifically, but also, as I've said before, in some ways, our conversation about vitamin K is different from our conversation about erythromycin ointment in particular, because the erythromycin ointment conversation is partly implies a certain amount of mistrust about what a family thinks they know about their child's infectious risk. But the vitamin K is a universal risk and something that we all share. And I think that being able to talk about those things with people respectfully and to some extent differently is part of the art of what we do.
Part of bringing this up and part of talking about the cases that actually have happened, there are a lot of things that happen in newborns that you may not see, right? So you may be a provider who has never seen an intracranial hemorrhage related to vitamin K. So our ability to share those stories with each other so that when you do have those conversations with families, you can really portray the gravity of what is going on. And I think that's one of those areas that we really would be better at being able to know about and share, particularly for things that have happened very uncommonly because of the practices that we've had.
Right. Why you haven't seen polio at your elementary school. All right, sir. Thanks so much for talking to us about this. I'm sure there will be questions. Please send your questions to questions@vcurb.com, and we'll address those in a couple of weeks. In the meantime, Dr. Lindgren, thanks for your time and expertise.
Thanks, Paul.
Thanks for joining us. We look forward to getting together again next time. The virtual curbside is available on iTunes or wherever you find your other favorite podcasts. Be sure to like us and subscribe. We want you to like us both because we're needy that way and because that will help other listeners like you find us. Check out our website, vcurb.com, for supporting materials, schedules, and other great stuff. The Virtual Curbside is an educational production of the Utah chapter of the American Academy of Pediatrics. The opinions expressed in this podcast, while carefully considered, are ultimately the opinions of the presenters and not necessarily of the American Academy of Pediatrics or our employers. And remember, the content of this podcast shouldn't be seen as a substitute for seeking actual personal medical care. If this is an emergency, hang up and dial 911. Otherwise, schedule a visit with a caring healthcare provider to try to get to the bottom of your concerns. None of this could happen without Elisa Stoddard, our extraordinary executive director of the Utah AAP. Many thanks to Tim Cosgrove for his help on the website and logo design. Production design and editing thanks to Paul Wirkus, who also composed the theme music. See you next time.